Hi, welcome to the 10th lecture in abnormal psychology. We're going to be talking today about psychotic disorders. So this is what we're going to cover in today's class. We're going to discuss what the clinical definition of psychosis is, and then describe the DSM-5 psychotic spectrum disorders. Delusional disorder, the disorders on the schizophrenia spectrum, and schizoaffective disorder. We'll also talk about the odd or unusual personality disorder cluster that is made up of paranoid, schizoid, and schizotypal personality. And then lastly, we'll touch briefly on the treatment of psychosis. Okay, so before we jump into defining psychosis clinically, I wanted to just show a video of someone who's experiencing psychotic symptoms, describing what it's like, and also demonstrating it.
Now they're all talking. They said I'm not crazy. They said just because you do crazy stuff doesn't make you crazy. My name is Josh. I'm from Westchester, Pennsylvania. I work part-time.
Everything should be straightened up a little bit before we start moving on.
I'm a laborer for construction. I don't really have education or anything, but I'm willing to do whatever people need me to do. And I have schizophrenia. Schizophrenia is something in your mind where you see or believe things are there when they may not necessarily be there. Oh man, look at this guy. I can feel what animals are feeling or saying, and it's cool. Okay, boy, nice man. I hallucinate. Anything I hear is gonna mean something. Sometimes they have I get really important stuff. It's not just a bird chirping, it's not just a dog barking. They're saying something to me. I was down here once and all these birds were like, I mean, you gotta go back to work. I didn't even know I had work. I can talk to a human and sometimes not get a straight answer, but I always get a straight answer from an animal.
Okay, so that video is a demonstration of someone who's experiencing psychotic symptoms. He describes both hallucinations, where he hears animals actually talking to him, and delusions, where he feels like he can communicate with animals and animals have important secret messages for him. And I think this is a really good illustration of the fact that, just like every other disorder we've talked about, psychosis and schizophrenia are on a spectrum with normal behavior too. So in his case, he has a delusion that he can communicate with animals. That doesn't differ that much from how a lot of people feel about animals, that they have a special connection with them, that they have empathy for them, that they can relate to them more than they can relate to people. The main area of difference is how literal his belief is, and how difficult it would probably be to disprove his belief that he can communicate with animals. But feeling like you have a special connection with animals isn't in and of itself all that unusual. Oops. Okay, so the definition of psychosis is an inability to distinguish between internal experiences and reality. We'll talk throughout this lecture about how all of the hallucinations and delusions and other symptoms of psychosis arise from biological brain dysfunctions. So everything that people with psychosis are experiencing as external, as coming from animals or voices outside of them or whatever, is all actually driven by internal experiences. So psychosis is also experienced as alterations in perception, cognition, behavior, emotion, and movement. The symptoms of psychosis can be divided into 3 different clusters: positive symptoms, which we talked about in that last video, hallucinations and delusions; negative symptoms, which all start with an A because they all refer to an absence of something, except for affective flattening. But avolition is just a lack of motivation, a lack of intrinsic desire to do things. Anhedonia, we've actually already discussed in the mood disorders lecture, is a flattening of emotion, or sort of an inability to feel strong emotions. Alogia is difficulty producing speech, so impoverished speech, slow speech, not giving elaborated responses to questions. Asociality is a lack of motivation to have social relationships or withdrawing from social relationships. And affective flattening is a difficulty in expressing emotion, whereas anhedonia is a difficulty in experiencing emotion. And then the third cluster of psychotic symptoms is also called cognitive symptoms, but disorganized as a broader umbrella because it helps to capture the erratic speech and behavior that can characterize psychosis, and also the cognitive deficits and problems that cause those behavioral abnormalities. So the disorganized symptoms are broken into disorganized speech and emotion, and inappropriate affect and disorganized behavior, which should have an R. And in the next couple of slides, I'm going to talk through what these mean and what they look like. And I'm going to play a couple videos, one video per symptom cluster. There are more videos in the slide set that offer more perspectives and more examples of each of these symptom domains that you can play on your own if you're interested. But in the interest of time, I'm only going to play about one per symptom cluster. Okay, so we're going to start with the positive symptoms. Hallucinations are having sensory experiences that are not grounded in reality. And the 5 types of hallucinations correspond to the 5 sensory organs. So you have auditory hallucinations, which is hearing things that aren't really there. Tactile or haptic hallucinations, which involves feeling things that aren't there, or feeling body movements that aren't happening. Visual hallucinations are seeing things that aren't there. Olfactory hallucinations are smelling things that aren't there. And gustatory hallucinations are tasting things that aren't there. I'm going to skip over this video, but you can watch it if you're interested. Oops, sorry about that. Not watching it right now. Okay. So in addition to hallucinations, positive symptoms can include delusions. For people with schizophrenia and severe psychotic disorders, delusions tend to be very elaborate, very widespread. People don't typically just have 1 or 2 delusions. They typically have a whole interconnected delusional belief system. But delusions are organized into basic themes. One of the most common themes is delusions of persecution. So believing that people or organizations are out to get you. A common one that one of the speakers in one of the videos will talk about is the delusion that doctors specifically want to hurt you or do experiments on you. Delusions of grandeur involve thinking or believing that you're more important than you are, or that you're someone in a position of power or authority when you're not. On the discussion board, we talked a little bit about how difficult it can be to distinguish between mania and psychosis. And in mania, grandiosity is one of the symptoms. So having elevated feelings about how important you are, how special you are. The line between grandiosity and delusions of grandeur can be hard to draw. It's easy to think of examples in the extremes of both. So something that would clearly be grounded in reality and not delusional, but still grandiose, could be someone thinking that it's a great idea to post 12 identical selfies, thinking that like people would be interested in seeing that. That's not delusional, it's not psychotic, but it does reflect elevated self-esteem and elevated sense of self that that person might not demonstrate in a euthymic state. On the other hand, believing that you're literally the president or that you're literally God is a common theme of delusions of grandeur. So that's clearly not based in reality, it's clearly extreme, but a lot of grandiosity and delusions fall somewhere in the middle. And delusion in mania is actually fairly common, so about 40 to 60% of people with mania experience psychotic symptoms at some point. So delusions of guilt or sin, kind of on the opposite spectrum from delusions of grandeur or grandiosity. And delusions of guilt or sin might be the type of mood congruent psychotic symptoms you would see in someone with really severe depression. So this is when someone feels like they're personally responsible for bad events that they couldn't logically have caused, or when they feel like they're dirty or corrupt or sinful in some characterological way. Delusions of reference are another common domain of delusions, where you feel like random events or sort of where you see patterns in random unconnected events and you think that those patterns are trying to tell you something. Somatic delusions involve alterations in how you perceive and think about your own body. So a type of somatic delusion could be feeling like a part of your body doesn't actually belong to you, that your own body part was replaced with an imposter. So feeling like your hands aren't your real hands. Erotic delusions are delusions that someone is in love with you when they're not, either because you've never met them or because there's someone actually in your life, but they don't have those feelings. Jealous delusions are sort of a paranoid belief that a partner is cheating on you. And then delusions of being controlled involve 3 different domains. So thought insertion is the belief that outside agencies are putting thoughts in your head that you didn't generate yourself. Thought withdrawal is kind of the opposite, that you're losing time or forgetting things because someone is taking the thoughts out of your head. And thought broadcasting, so feeling like other people can hear your thoughts, or if you're not careful, you'll accidentally broadcast your thoughts without speaking. So delusions of being controlled and thought insertion, broadcasting, and withdrawal are probably where the stereotype of people with psychosis wearing tinfoil hats comes from. That could be a behavior that people do to prevent like radiation or electromagnetic rays or whatever from getting into their head and taking out their thoughts because of delusions of being controlled. Okay, so we've seen this YouTuber before. She's an advocate for people living with schizophrenia. And this is her talking about her first psychotic episode and some of the delusions and hallucinations she experienced then.
I was so afraid of what people would think if they found out what I had been going through, so I mostly kept things quiet and to myself, which really didn't help things at all. I struggled a great deal with my mood, and it was around this time too that I started to hallucinate regularly as well. So it began with just hearing my name spoken aloud every now and then, even when I was completely alone. I kind of just initially brushed this off though, thinking that my imagination was just running amok or something like that. And so I never confided this in anyone, and I never told my counselors or my doctors at the time. I then began to have olfactory hallucinations where I would smell these really awful smells that I couldn't identify and I couldn't locate the source of. It was really kind of a weird and confusing time for me. I struggled silently with these symptoms for quite a while, and a year after my first suicide attempt, I attempted again, but this time it was quite a bit more serious. So I overdosed again, and for whatever reason, my counselor at the time later told me that he just got this really bad feeling that something bad had happened to me that morning. I hadn't given him any indication that I was going to do anything. I hadn't told him that I was going to do anything, but he just got this visceral feeling that something bad had happened. And so he decided to send the police to do a wellness check on me. So the police arrived just in time to see what had happened and to rush me to the hospital, where I was put into a medically induced coma and was kept on life support for several days. Obviously, I made it through, but throughout all of this, my psychiatrist had been trying me on a plethora of different medications to try to reduce the symptoms that I had been experiencing. We decided eventually to try a bit of a different approach and to try electroconvulsive therapy. It's a therapy that works for a lot of people, but long story short, for me, it did not work, and I was left with memory deficits as well. So things kind of stabilized, and I was able to return to school full time, and I started a practicum placement that I really, really loved, doing research at the university. This went pretty well for almost 2 full semesters until I had my first full-blown psychotic episode at the age of 24. So during this time, the hallucinations intensified, and I became delusional as well. So I was hearing and seeing helicopters circling overhead, and I was hearing voices. I became obsessed with retrieving my medical files, as I was convinced that the doctors were conspiring to kill me or using the medications to poison me or for mind control. I hardly slept at all and was just flying off the walls with this paranoid energy. I was sleeping in my car outside of the clinic, waiting for it to open again in the morning so that I could go in and again try to obtain access to my files. I remember one particular night of doing this where I hallucinated an elderly man who was trying to break into my car to reach in and steal my files from me.
Okay, so you can watch the rest of the video to hear more about her eventual diagnosis and how she manages her symptoms now. But that's just sort of an example of what positive symptoms in schizophrenia can look like. Delusional paranoia, feeling that you're being persecuted, and then hallucinations that are kind of consistent with that. So if you believe that the government's after you, hallucinating helicopters circling overhead, people trying to steal important information from you. Okay, we're going to skip over this one and talk a little bit about the negative symptoms. So an important reminder, the difference between positive and negative symptoms doesn't refer to positive symptoms being in any way better in terms of how they feel or their prognosis, although positive symptoms do actually currently have a slightly better prognosis. People who have psychotic disorders with only positive symptoms tend to have a better response to medication and tend to be more functional in their lives than people who have predominantly negative symptoms, for reasons that we'll talk about a little bit later. So what positive actually refers to is having an excess of something that isn't usually present. So people with positive symptoms are having experiences that other people don't have. They're having auditory and visual hallucinations, seeing and hearing things that aren't there. Whereas negative symptoms refer to an absence or a deficit in normal functioning. So again, those negative symptoms are a lack of motivation, a lack of emotional experience, poverty of speech, a difficulty communicating, lack of social motivation, not feeling connected to other people, and difficulty expressing emotions. I'm going to skip over this video, whoops, and this one, but I would definitely recommend watching them for this description of by someone who's currently not in a full psychotic episode, who's managing what we'll later describe as residual positive symptoms. So the positive symptoms that can hang around even after, residual negative symptoms. So the negative symptoms that hang around even when acute psychosis is managed.
Hi, I'm Randall, author of the blog Creative Schizophrenia on Healthy Place. I'm taking this video in front of a giant piece of cardboard because our renovation project is completely ripped up. I have a giant zit on my forehead even though I'm almost 30 and I'm not supposed to get zits anymore. And I have a big scratch on my face from my 1-year-old son scratching me. Why am I starting a video this way? Well, I'm trying to be a little bit more unscripted, a little more spontaneous, and show a little more emotion, which ties into my topic for this video, which is negative symptoms of schizophrenia. It may come as a shock to you, but I used to do quite a bit of acting when I was in high school. I was lead role in a couple of musicals. I was no Robert Duvall or Tommy Lee Jones, reference to Lonesome Dove, my favorite movie, or Liam Hemsworth, who my wife wanted thrown in there because she thinks he's hot. But I was a pretty good actor and had good emotional range. But since I began exhibiting symptoms of schizophrenia, it's been very difficult to show emotion and to feel emotion. Now, the feeling emotion part is something that I talk more about in my post, but showing emotion was not something I realized that I had such an issue with until my wife pointed out to me that she noticed that I was smiling a lot less, laughing a lot less, more of monotone expression in my voice, just basically showing less emotion. And so showing emotion and being spontaneous is something that I really have to work at if I want to be more like that. Now, in terms of feeling more emotion, which is probably the bigger issue with negative symptoms of schizophrenia, it's really an uphill battle. I don't feel much joy in things that used to bring me a lot of joy, even when I'm not feeling depressed. I avoid spending time with others. I avoid spontaneous activities. I don't talk as much as I used to, especially when I'm not feeling well. And it's really hard. It's hard to live life when you essentially don't feel like you're getting anything out of life. And so my message to those of you who may be experiencing the same or similar symptoms is to find those reasons that you are living and focus on those reasons and focus.
Oops, sorry, I didn't mean to cut it off right there, but it was towards the end anyway. So this video really illustrates one of the reasons why negative symptoms have a poorer prognosis. Reason one, as we'll talk about later, is that the medication treatments that we have for schizophrenia tend to work better for the positive symptoms than the negative symptoms. But as this person articulated, negative symptoms can really take away a lot about what makes life enjoyable for people. It takes away motivation, it takes away enjoyment, it takes away friendships, it takes away the ability to communicate either with words or non-verbally. So negative symptoms are very difficult to live with, and they are the biggest cause of impairment for people with psychotic spectrum disorders. Okay, so lastly, the disorganized symptoms. The first of the two disorganized symptoms is broadly called disorganized thoughts. Subjectively, what the person is experiencing can be just a feeling of difficulty thinking or focusing, feeling like their thoughts are racing, like they have too many thoughts and can't turn them down, or feeling like their thoughts are abnormally slow. It can also be experienced as memory deficit, so just not being able to, like losing time, not being able to remember things, losing track of things. When disorganized thinking is more severe, thoughts are basically illogical, only seemingly tangentially connected or even unconnected. It isn't to say that the thoughts are actually unconnected. It's that the connections are so loose and so tangential that it's difficult for someone speaking to that person to understand how they're connected. So disorganized thoughts, when someone is acutely psychotic, it often has to be inferred from how they talk and how they communicate. When someone's speech is really difficult to follow or even incomprehensible, that's a sign that their thinking is probably disorganized. So the three types of disorganized speech that psychiatrists and psychologists look out for when diagnosing psychosis are derailment or loose associations, where people just sort of jump between different seemingly unconnected ideas and seem like they're losing their train of thought, or the connections between the things that they're saying aren't clear to the person listening. Tangentiality is when a person gives responses to direct questions that don't seem to be related to the question that was asked. And the most severe manifestation of disorganized thinking is incoherence or word salad, where people speak really fluently, using kind of appropriate grammar and syntax, but the actual words that they're using don't seem to make any sense. Incoherence is usually a very late stage symptom of poorly treated or untreated schizophrenia. It's also seen in the late stages of Alzheimer's disease. So it's probably a sign of really severe cognitive degeneration. The subjective symptoms of just sort of having difficulty concentrating or feeling racing thoughts, and the more subtle signs like derailment, loose associations, and tangentiality tend to be more common. Okay, so this is a real person in an older psychiatric demonstration video demonstrating derailment and a little bit of incoherence, although, as I'll point out at the end, a lot of the difficulty in understanding her speech comes from medication side effects, not the symptoms of schizophrenia.
What do you drink? What do you eat? Do you realize that I have a monopoly over the coffee industry? Okay, and so that's the problem, isn't it? That's the complaint, right? Well, I have kryptonite in it. You know what that is, don't you? Kryptonite? And, so if I have kryptonite in, I drink coffee and soda, and no one else knows what to eat. I mean, you live on raw eggs? Do you live on raw eggs? To eat raw eggs. When I was pregnant, I think boys get pregnant and girls don't. It's true. But I ate raw eggs. But do you eat raw eggs? No. What do you eat and drink? Is that the big problem?
Okay, so there's a little bit of incoherence in this video. I don't think that part of it was a great demonstration. What she's really demonstrating is derailment and loose association. So she starts off talking about coffee, and then she moves on to the delusion that she has kryptonite in her body. And then that reminds her of like eating and drinking habits for a reason that's not that clear to the person talking to her. So she starts talking about eating raw eggs when she was pregnant, the difference between boys and girls getting pregnant. So you can see that these things are sort of connected in some way, but the connections are really loose and tangential. Her speech is a little difficult to understand, but that itself is not incoherence. Speech difficulties like slurred speech and difficulty swallowing, problems with muscle coordination in the mouth, is a common side effect of especially first-generation antipsychotic medications. It's part of a group of motor side effects collectively known as extrapyramidal effects. And problems with oral motor coordination caused by these drugs are often incurable, and they persist even after the person's off the drugs. So that's probably why her speech seems slurred, but the content of her speech not making a lot of sense is an example of severe disorganized thinking. Okay, I'll just play this one too. This is an actor, but it's a demonstration of tangential responses.
Tell me, why did you come to the hospital?
To teach.
Okay, so that wasn't
Teach.
tangential.
What do you teach?
So are the training 1 years?
Have you started teaching here at the hospital?
For urine tests.
Pardon?
Urine tests.
Okay, so those were tangential responses to questions. I'm not going to play this one, but this is someone who's not currently experiencing those symptoms talking about what it's like, talking about the subjective experience of having disorganized thoughts. So I would recommend watching it on your own if you're interested in learning more about that. Okay, so the other category of disorganized symptoms is disorganized behavior. And this is a fairly broad group of motor disturbances. One of the more common ones is having inappropriate emotional responses where a person's expressed emotions don't match the content of what they're talking about or the situation that's going on. Just psychomotor agitation, which is also a symptom of depression and mania, is a form of disorganized behavior. People with these symptoms can sometimes act inappropriately for their age, act younger than they are, or they can just engage in a lot of repetitive motor behaviors that aren't goal-directed and seem sort of purposeless. Similar to self-stimulating behaviors that you might see in people with developmental disorders, but those behaviors aren't purposeless. They serve a self-stimulatory function. Disorganized behavior in schizophrenia is thought to be the result of neuromotor abnormalities. And so these behaviors really are not conscious, not intentional. The other category of disorganized behavior symptoms is catatonia, which is a lack of responsiveness to outside stimuli. So at its most extreme, catatonia can just look like complete immobility and a total inability to respond, even to things like pain. But catatonia is somewhat on a spectrum. So other more subtle signs of catatonia would be a lack of movement, lack of responsiveness to command. So people with catatonia have difficulty following directions even when they want to. They also tend to have difficulty inhibiting automatic responses. So things that we do habitually, like when someone reaches out their hand to shake our hand, reaching out, that's kind of a habit and a reflex. People with catatonia can't inhibit that reflex even when they're actively trying not to. So I'm just going to show a demonstration of inappropriate emotional responses to illustrate disorganized behavior, but the next video is a demonstration of catatonia that you can watch if you're interested.
And every day he's always fighting with me. Michael's always fighting with me. Drug dead, geek, retarded bitch. Oh, that stuff doesn't mean shit to me anymore. I'm so used to it. I do have a brain problem. But I don't have a brain tumor.
Okay, so that's an inappropriate emotional response in that the emotion she's demonstrating, laughing, doesn't really fit with the content of what she's talking about. And it's not congruent with her mood state. Okay, so I'm gonna skip over the catatonia video. But the broad takeaways from this are that psychosis is in and of itself not its own diagnosis. It's a symptom, and it can be a symptom of many different diagnoses. So as we've already talked about, psychosis can co-occur with depression or mania. Psychosis can be caused by drug intoxication. It can be caused by medical illnesses especially ones that involve brain inflammation, or a fever so high that it starts to cause brain damage. Psychosis can be caused by organic brain diseases. It's really common to see in the late stages of Alzheimer's. But in the realm of clinical psychology, one of the more common causes of psychosis that psychologists encounter is schizophrenia or another psychotic disorder. Psychosis is also a spectrum, so even though it is a really serious, severe symptom of mental illness, psychosis itself can range from relatively mild symptoms to much more severe ones. So later in this lecture, we'll talk about attenuated psychosis, which is an example of mild manifestations of psychotic symptoms that often develop into full-blown psychosis or more severe psychotic symptoms. But isolated positives, especially positive psychotic symptoms, are surprisingly common in non-psychotic populations. So there's a range of estimates, but somewhere between 5 and 25% of healthy people experience auditory hallucinations, so hearing things that aren't really there. In the majority of those cases, the hallucinations aren't associated with any disorder, and they're just kind of random variances in experience that people have. One example of a non-pathological auditory hallucination or visual hallucination, or actually tactile hallucination, really any kind of hallucination, is hypnopopic and hypnagogic experiences. These are really vivid images and physical feelings that people have during the transition from sleep to waking. So either just as they're falling asleep or just as they're waking up. It's not dreams. Dreams only occur during the REM stage of sleep. So what it is a product of changes in neural activity and a slight disorganization in normal brain activity that happens as the brain is sort of shifting from awake activity to sleep activity. But subjectively, the experience a common one is feeling like you're falling. So a lot of people will experience, just as they're falling asleep, a sensation of falling that like jerks them awake. That is a hallucination. It's not a symptom of schizophrenia, and it's not a symptom of psychosis if it happens in isolation. Okay, so now I'm going to just run through the psychotic disorders, here's an outline. So we'll be starting with delusional disorder and then talking about the full schizophrenia spectrum. So attenuated psychotic disorder to brief psychotic disorder to schizophreniform disorder to full-blown schizophrenia. And then we'll touch on schizoaffective disorder and the odd, unusual cluster of personality disorders. Okay, so delusional disorder is characterized by having one or more delusional belief for at least a month. Hallucinations can be present in delusional disorder, but not in the majority of cases. And when they are present, they tend to be mild, and they tend to be associated with the content of the delusion. So an example could be the YouTuber from the Living Well with Schizophrenia channel who talked about having really strong paranoid delusions that people were out to get her and that doctors were experimenting on her. And then also having hallucinations of helicopters circling. That's the type of hallucination that is relatively mild and that can be associated with a delusional belief system in delusional disorder. Overall, though, despite having delusions and sometimes mild hallucinations, people with delusional disorder tend to have generally normal functioning. Although their functioning is impaired, it's only impaired in domains related to the delusional belief. So for this reason, as we'll talk about in a couple slides, although delusional disorder is said to be rare, it's probably a lot more common than we realize, and we just don't know how common it is because most people who have it don't think that they're sick and aren't impaired enough to ever seek treatment or be pushed into treatment by their family members. So what we do know from research studies of people who did seek treatment, so they might not be representative of everyone who has delusional disorder, but people who seek treatment for delusional disorder, the most common type of delusion that people have is persecutory delusions. And this is true of the schizophrenia spectrum too. Persecutory delusions are just really common. Also common are jealous delusions and then mixed delusions. So people who don't fall into one of the categories of delusional belief that we talked about earlier. Jealous delusions are probably likely to be more common in these kinds of samples because jealous delusions often involve impairment in close relationships. So people close to the person having these delusions would realize that something is going on in a way that people might never realize if the delusional belief system wasn't directed at them. So I'm going to talk a little bit more about two other categories of delusional beliefs that are common in delusional disorder. The first is folie deux, which is an older psychological term that refers to madness shared by two people. And then we'll talk a little bit about delusional misidentification syndrome. So Cotard syndrome, Capgras syndrome, and Fragile syndrome. So a recent example of possible folie deux that was in the news like a couple of years ago was the Slender Man stabbing, where two 12-year-old girls attempted to murder their friend by stabbing her in the woods because they believed that Slender Man wanted them to, and that when they did it, they would be able to go and live with him in the forest. So the girls who did this were described as being really socially isolated and only really being friends with each other, being really creative and having a very rich fantasy life that involved Slender Man. But the key is that one of them actually also had symptoms of psychosis. So she had psychotic symptoms before the Slender Man stabbing, and she continued to have psychotic symptoms after both of them were in prison. The other girl didn't have psychotic symptoms before this friendship, and once she was separated from her friend, she no longer had any psychotic symptoms. But while they were together, she shared in this delusional belief system that Slender Man wanted them to kill people for him. So before I move on, just an important caveat that I probably won't get another chance to touch on in this lecture is that there is a stigma around people with psychosis and schizophrenia, that they're violent or dangerous in some way. And what's actually true is that people with psychotic symptoms are more likely to be victims of crime, especially victims of violent crime, than they are to be perpetrators. The stigma comes from somewhere though, and part of it is just that people with psychotic symptoms do have more criminal convictions, more contact with the criminal justice system for reasons related to social class, policing of homelessness, survival crime, and just the fact that psychotic disorders are so disabling and so impairing that many people with these symptoms have a difficult time maintaining employment and relationships and housing. So that can lead to them living the type of sort of marginal lives that lead to being victims of crime and harassed by the police. Okay, so the textbook makes this distinction between motivational and deficit models of delusions specifically, but this can somewhat apply to other positive symptoms too, so it can apply to hallucinations too. The way the textbook describes it, the motivational model is sort of psychodynamic and separate from a biological understanding of psychopathology, but it doesn't have to be understood that way. The basic definition is that delusional belief systems either develop or are maintained by reinforcement in the environment. So one form of reinforcement is negative reinforcement. Delusional beliefs might help someone escape from anxiety or depression or life stressors. So a really psychodynamic way of looking at a delusion could be to think, so someone who has an erotic delusion that a celebrity is secretly in love with them. A psychoanalyst might say, you know, you're just really lonely and you never were able to express love and affection for people in your real life. So a way of dealing with your loneliness and feeling like you have love in your life is to develop this delusion. So the delusion is motivated by loneliness and it helps to escape from that negative feeling. Sorry, I'm just gonna skip over that stuff for a second to introduce the deficit model, which is a belief or the understanding that delusions actually result from cognitive dysfunction. So psychotic symptoms are biologically based. They arise from brain dysfunctions that many of which we can actually pinpoint, and we'll talk about that in a few slides. But delusions result from brain dysfunctions that cause abnormalities of perception and cognition. So both of these things can be true. Someone who has a lot of vulnerability for psychosis, so who has some of the deficits that can lead to the alterations in perception and cognition that are required to create delusions, can still experience environmental reinforcement for those delusions. So belief in an already existing delusion can be reinforced by the environment, including the delusion can be a way to escape from painful emotions or to avoid emotions. Similar to schemas that we talked about in the depression lecture, delusions are a belief system, and belief systems influence the way that we organize our experiences and interpret the world. So people with delusions can engage in cognitive distortions related to their delusions, like filtering, seeing random events as signs that your delusion is true, and kind of ignoring all the random events that don't support the belief that your delusion is true. And similarly, overgeneralizing. So taking examples that support their delusion and extending them to other domains where no evidence supports their delusion. In addition, over time, having a delusional belief can become self-reinforcing because people organize their lives and experience so much around this belief that admitting it's not true or giving up on it could be really humiliating or really destabilizing. So the motivational model can explain the persistence of delusions in some cases. And one thing the motivational model can really do is explain how folie deux arises. So the motivational theory of folie deux is that delusions develop in the partner who doesn't have acute psychosis because they're motivated to maintain their relationship with their psychotic partner. And folie deux typically happens between close friends, romantic partners, and parents and children. So it happens in close relationships where one partner is psychotic and one partner isn't acutely psychotic, but has enough risk factors that they're able to buy into the delusional belief enough that it helps them to maintain their relationship with the person who's psychotic, and it helps them to avoid their own anxiety about losing the relationship, or it helps them to avoid negative interactions with the psychotic person. So it's reinforced, motivated by reward in the environment. So a really clear-cut example of how delusional beliefs can arise from specific brain deficits has to do with Capgras syndrome or delusion, which is an example of a delusional misidentification syndrome. So the Capgras delusion is when the delusional person believes that people close to them have been replaced by impersonators. So an example of that kind of is the movie Coraline, where the protagonist feels like her mother has been replaced by a duplicate who looks just like her mother but isn't in some way. A related delusional misidentification syndrome is the Folie delusion, which is the belief that several seemingly different people in the patient's life are actually all the same person who is just playing multiple roles. And then lastly, the Cotard delusion is a belief that the person experiencing the delusion is dead. So a related concept that is not a delusion and not a symptom of psychosis, but that is related to identifying faces and people is prosopagnosia. So prosopagnosia is a really specific deficit in recognizing faces. Some signs that you might have, that you might be somewhere on the spectrum of having this deficit, because it is a spectrum, is having difficulty recognizing someone when they change their hairstyle or the way that they dress, having a hard time keeping track of characters in movies because you can't tell them apart, not recognizing someone when you see them out of context. So like when you see a classmate in a different city, or when you see your coworker outside of work, or even not recognizing old pictures of yourself. If you're interested in prosopagnosia and learning a little bit more about it, there's a further extra credit reading on it. And also these links go to tests you can take to see how your facial recognition compares to other people's. So what does prosopagnosia have to do with the Capgras delusion? So this is an example of parallel processing in the brain, where visual information is simultaneously processed by multiple different brain regions. So when people with Capgras delusion see a face, so say for example, Brad Pitt, they're able to recognize him. By contrast, oh, sorry, the animations are really screwed up here. So by contrast, people with prosopagnosia, when they see this picture of a celebrity that most of us recognize, they can't quite place him. They can't consciously articulate who he is. However, if their skin conductance response is recorded, you can see that they experience emotional arousal when they see this picture. So even though consciously they don't know who they're seeing, emotionally they're having a reaction to it. On the other hand, when people with the Capgras delusion see a familiar face, they recognize it. They have no problem seeing how these facial features line up with a person who they recognize and remember. Oops. But they don't have an emotional reaction. Their skin conductance reading doesn't change. So even though they're recognizing the person consciously, they aren't responding emotionally. So people with prosopagnosia have an appropriate emotional response even when they don't recognize who they're seeing, whereas people with Capgras recognize who they're seeing but don't have an emotional response. So how does this play into a delusional belief system? So it's believed that prosopagnosia is a deficit in one of the streams of visual processing known as the ventral stream, where information coming in from the eyes goes back to the occipital lobe, the visual cortex, where visual information is processed consciously. And then from there, this information goes to the temporal lobe, which is where we store memories and how we recognize and verbalize our recognition of things in our environment. So one pathway from the visual cortex goes to the fusiform face area, which is a brain region that specifically responds to faces. So it's a brain area that's fully dedicated to recognizing people. People with prosopagnosia have a deficit right here in the fusiform face area. It doesn't work as well as it should. So they're unable to specifically recognize faces. People with delusional misidentification syndromes, this pathway works perfectly well. But what's impaired is a different pathway that processes visual information totally non-consciously. So visual information, the first relay in the brain is in the thalamus, which then sends information to the visual cortex, that's the first area where we consciously perceive vision. But in addition to sending visual information to that conscious part of our brain, the thalamus also sends that information directly to the emotional part of our brain, the amygdala. And this happens because humans and animals need to be able to recognize and respond to threat faster than we consciously perceive it. So the thalamus to limbic system connection helps us have appropriate emotional responses even before we recognize what we're seeing. And this emotional processing of visual information is what's impaired in delusional misidentification syndromes. So what happens when someone with the Capgras delusion sees a picture of, say, their mom, they recognize that it's their mom, but they're not having the normal emotional response that they are used to having to their mom. So kind of a logical conclusion for them to come to is that even though this person looks exactly like their mom, it isn't their mom because they don't have the same feelings about her. So what would explain that? It must be an imposter who's just pretending to be their mom. So that's kind of an example of how a specific deficit in brain processing, a problem with one brain circuit, can lead to alterations in perception and cognition that are elaborated and developed into a delusional belief system. And there's really no motivation to not recognize your mom. Any psychodynamic explanation isn't sufficient to explain the Capgras delusion in everyone, but what is sufficient to explain it is this lack of emotional response to familiar images. So deficits can also explain hallucinations. So even though I said that these are positive symptoms in that they're extra experiences that most people don't have, they are still caused by deficits. So before I talk about one of the deficits that can explain hallucinations, I want to introduce this interesting distinction in the way that people think. So this tweet was really popular earlier this year. Fun fact, some people have an internal narrative and some don't, as in some people's thoughts are like sentences that they hear, and some people just have abstract nonverbal thoughts and have to consciously verbalize them. And most people aren't aware of the other type of person. So this tweet went viral because it's true. There are people who all their thoughts are verbal and spoken like sentences, and there are people who really can't relate to that way of thinking because all of their thoughts are nonverbal. So one theory of where auditory hallucinations specifically come from is a misunderstanding of subvocal or internal speech. So when people with psychotic symptoms are doing this process where their thoughts are happening in sentences, where they're silently and unconsciously verbalizing all their thoughts, people with psychosis just have difficulty realizing that that's coming from inside and not outside. So this illustration is showing one brain region that might be involved in that understanding. So the dark line is patients with schizophrenia and the light line is control patients. They were instructed to either listen to speech played through headphones or listen to their own internal monologue while lying in an fMRI machine. When they were listening to speech through headphones, both patients and controls had a lot of activation in this region called the left superior temporal gyrus. It's a part of the temporal lobe, and one of its jobs is to process incoming auditory information and interpret it as speech. So this brain region should be really active when we're hearing speech from outside. But in healthy people, this brain region is not active when they're engaging in inner speech, when they're hearing their own thoughts. The suppression of that brain region is much less pronounced in patients with schizophrenia. So what seems to be happening is that the brain of people with schizophrenia is responding in exactly the same way to outside speech as it is to inside speech. And so they're experiencing some of their own internal thoughts as in the same way that they experience auditory input from outside. So other evidence that hallucinations and nonverbal speech are coming from the same place is that when people are engaged in inner speech and when people are hallucinating, they have subtle activation of their vocal muscles. So when they're wearing an EMG, which is an instrument that measures electrical activity in muscles, their muscles are a little bit tense and active when they're engaged in subvocal speech and when they're having hallucinations, even though they're not actually talking. When hearing voices, when having hallucinations in an fMRI machine, patients with schizophrenia show activation in Wernicke's area, which is a part of the temporal lobe that's involved in processing speech. It's near the left superior temporal gyrus. It's activated when we're hearing auditory input that sounds like speech, and it helps us make sense of and understand that speech. Oh, shoot, I'm sorry. Oh man, okay, so that's not true. Forget I said that. Wernicke's area is in the left superior temporal gyrus, and it helps us understand external speech. That's what this is showing. That region is not suppressed when patients with schizophrenia are producing their own internal speech. So that's the evidence that patients with schizophrenia are experiencing their own internal speech like it's outside speech. But a corollary to that is that when they are having hallucinations, they have activation in Wernicke's area, which is the area of our brain that helps produce speech. So the area of our brain that helps us understand and organize speech is called Broca's area. And that area is not activated during an auditory hallucination as much as Wernicke's area is activated. So what this is suggesting is that speaking and having hallucinations are activated by the same brain region, but the brain region that should be suppressed when we're hearing our own voice internally isn't suppressed. So it's evidence that auditory hallucinations are internally produced in the same way that speech is, and the brain just has trouble recognizing that that speech is not coming from outside. So in addition to the fact that at least a majority of people engage in subvocal speech to some extent, even if not all of their speech is verbalized, or sorry, not all of their thoughts are verbalized, a smaller but still pretty significant number of people say that they actually think in multiple voices. So when they're thinking and engaging in subvocal or inner speech, they're actually hearing that in voices other than their own. So again, these people aren't experiencing psychosis. These are healthy controls. But when someone with psychosis, when someone who has these difficulties interpreting the difference between inner speech and outer speech also happens to think in multiple voices, you can see how they would be suddenly hearing voices from outside. So hearing other hallucinated voices. Okay, so sorry for misspeaking there. I will try to explain this again in class in case I manage to confuse anyone. But basically the gist is that hearing voices, that's what these slides are related to, but other hallucinations too, can be related to the brain's inability to recognize its own internal processes. So the brain using the same regions and the same processes that are used to process external sensory input to process internal thoughts that can give rise to hallucinations. Another possible deficit that can give rise to, in this case, visual hallucinations and auditory hallucinations is a deficit in sensory gating. So when people are at risk for psychosis or have psychotic symptoms, they show deficits in sensory habituation. So the ability to stop responding to and ignore irrelevant sensory inputs. And we've talked about habituation in the context of fear and anxiety. Habituation is the way that we get over fears. When you're repeatedly exposed to a stimulus, your brain will eventually stop paying as much attention to it because it learns that that stimulus isn't conveying new or important information. Habituation happens at a sensory level all the time. So like when you're wearing clothes, you don't notice the feeling of clothes on your body because it doesn't change and it doesn't convey any new information. So your brain just shuts it out. People with schizophrenia have impairments in that process. So when stimuli enter our conscious awareness, we tend to interpret them. It's natural and normal for the brain to look for patterns in stimuli. That's how we organize our perceptions. The problem is that if you have a deficit in sensory gating, you're getting a lot of irrelevant sensory input and your brain is still trying to process and understand it. And that can give rise to hearing, seeing, feeling, tasting, smelling things that other people don't think are there. It's not that they're not there, but they're occurring at a level that's so minimal, so low, that your brain should ignore it. And since it's not, your brain is trying to find patterns and information that isn't meaningful. So some examples of this that you've probably experienced is things like seeing faces in clouds or seeing faces in the burned patterns on toast, hearing words in static, or like if you're interested in ghost hunter shows, those EVP recordings that just sound like static, but people try to make sense of them and hear ghost voices in them. Also, people hearing scary messages and songs played backwards is an example of making sense of random irrelevant sensory stimuli. All right, well, that video is not working. That's all right. Okay, so some takeaways from delusional disorder. It is rare to have it diagnosed. Only between 2 and 8% of people with psychotic disorders are diagnosed with delusional disorder, and that comes out to 0.005% of the population. So a really small number of people diagnosed. But that's probably because this disorder is defined by having good overall functioning. And most people with delusions don't believe that their delusions are delusions. They think that they're real, understandably. So a lot of people with delusional disorder probably don't seek treatment and probably aren't impaired enough to really need it. An example that illustrates that delusional disorder is probably more common than this prevalence estimate here from the textbook is the prevalence of the gang stalking delusion, which is a delusional belief that some secret agency or entity is trying to harass you and discredit you and make you feel crazy by sending multiple people every day to stalk you and follow you around. What's happening is that people are seeing patterns that aren't there. They're interpreting every random person on the street or every sort of unusual encounter with another person as a sign of this massive conspiracy against them. But gang stalking delusions have been estimated to have a prevalence of somewhere between 0.2 and 0.7%, which is way more common than 0.005%, but definitely a delusion. So just an illustration that delusional disorder is almost definitely more common than we know. It's by definition less severe than schizophrenia and schizoaffective disorders, but it involves shared risk. So the deficit model explains both delusional disorder and other psychotic disorders on the schizophrenia spectrum. Delusions and hallucinations are caused by deficits in brain processing, but that doesn't mean that motivational mechanisms can't help to maintain them. And some of the same mechanisms that we talk about when we talk about cognitive therapy, such as attributions based on the delusional belief system and cognitive distortions rooted in the delusional belief system. Okay, so let's talk about the schizophrenia spectrum now. So these are the current disorders in DSM-5 that are on the schizophrenia spectrum. Brief psychotic disorder refers to having 2 or more psychotic symptoms for anywhere between 1 day and 1 month. Schizophreniform disorder involves having these symptoms for 1 to 6 months. And when someone has had psychotic symptoms for 6 or more months and has impairment in multiple areas of their life, then they can be diagnosed with schizophrenia. So these are on a spectrum and they are showing a progression in time because a majority of people who have brief psychotic disorder are just in the early stages of schizophrenia. And when those symptoms eventually persist beyond 6 months, then they can be diagnosed with schizophrenia. Some people do spontaneously remit from brief psychotic disorder and schizophreniform disorder, but it is relatively unusual. So the schizophrenia spectrum is defined by the presence of 2 or more psychotic symptoms, and positive symptoms here are broken up into delusions and hallucinations, and disorganized symptoms are broken up into disorganized speech and disorganized behavior, whereas all the negative symptoms fall under one umbrella category still. So negative symptoms also are in brackets because negative symptoms are not considered common in brief psychotic disorder or schizophreniform disorder. They're more specific to schizophrenia. And that just mostly illustrates that schizophrenia is the most severe disorder on this spectrum, and negative symptoms are the most severe psychotic symptoms. So to be diagnosed with schizophrenia, as I said, a person needs to show markedly decreased functioning in 1 or more areas of life, or when schizophrenia has a childhood onset, a failure to achieve normal levels of functioning. Patients with psychotic symptoms often are unaware that they're ill. That process is known as anosognosia. Like bipolar disorder, and unlike anxiety and depression, the gender ratio in schizophrenia is pretty equal. So men and women are equally affected by schizophrenia in terms of population prevalence, but men tend to have an earlier onset of symptoms, so late teens to early 20s, whereas women are more likely to have their first psychotic episode in their mid to late 20s. Women also may have a better prognosis for schizophrenia. it could just be because women have more biological protective factors that we'll talk about later. And it could also have to do with the later age of onset, allowing women to have more complete cognitive development and better premorbid functioning, which are good prognostic indicators. So overall, schizophrenia does have a really poor prognosis, which means that the chances of recovery are not that good. So of all people with a first schizophrenic episode, so meeting those symptom criteria for 6 months and having impaired functioning, only about 1 in 5 people with schizophrenia actually recover from their disease. And by recover, I mean they live out the rest of their life without having any more psychotic episodes. There is a higher recovery rate for shorter durations schizophrenia spectrum disorders. So if someone never progresses to full-blown schizophrenia, if their psychotic episodes last less than 6 months and don't cause that much impairment, those psychotic episodes are less likely to recur, although they do still have a high rate of recurrence. As I said earlier, patients with a lot of negative symptoms of schizophrenia have the worst prognosis. It could just be that negative symptoms are a sign of greater neurological impairment because, again, they're an absence of normal processes. But as we talked about, positive symptoms also are rooted in neural dysfunction. So it could also just be that we have a better understanding of the type of neurological dysfunction that causes positive symptoms, and our treatments target that dysfunction better than whatever dysfunctions are at the core of negative symptoms. And we'll talk about that theory in a few slides when we talk about the relationship between the dopamine system and psychosis. So the course of schizophrenia is what's known as waxing and waning, where sometimes psychotic symptoms are worse and sometimes they're better. But for most people, at least for 4 in 5 patients with schizophrenia, the disease is progressive and degenerative. So brain functioning tends to get worse over the course of the person's lifetime. Overall functioning in life becomes more and more impaired, and psychotic symptoms become basically more and more permanent. When people show symptomatic improvement, their improvement is further and further away from their baseline, and their sort of normal becomes more and more impaired as they live with more residual symptoms. So this is just an illustration of that progressive waxing and waning course. So here, endophenotype refers to behaviors and psychological processes that help to explain the link between genetic risk and the symptoms of, in this case, psychosis. So endophenotype refers to deficits in behaviors that aren't themselves symptoms of psychosis, but that help explain the genetic risk for psychosis and help explain what brain processes might be impaired in people who have psychosis. So I'm going to first talk about the premorbid stage of the schizophrenia spectrum and what impairments are present that might indicate what biological systems are abnormal and impaired in someone with acute psychosis. So a lot of what we know about what's known as the schizophrenia prodrome, or the time before the onset of full-blown psychotic symptoms, comes from high-risk designs, where the children of parents with psychosis are followed prospectively to see which ones of them develop psychotic symptoms later in life, or compared with control kids. The comparisons with healthy controls are based on the endophenotype theory, so the belief that all children who have a parent with schizophrenia have some genetic liability to schizophrenia, and therefore that genetic liability should show up in subtle abnormalities in their cognition and behavior, even if they never develop full-blown psychotic symptoms. So we know that children who have one parent with schizophrenia have a much higher than typical chance of developing the disease themselves, about a 17% chance. And that chance gets even higher when children have 2 parents with psychosis. So by recruiting these children, we're able to come up with samples that have a really high rate of psychotic symptoms and also that have a lot of genetic liability for psychosis. So some early child development risk factors that have been identified in high-risk studies, so ways that children with a lot of schizophrenia risk genes differ from their peers, are that they tend to have subtle neuromotor abnormalities from basically birth. From the moment they're born, their motor development is a little bit different than other people's. They show problems with coordination. Their motor development may be nonlinear, so it'll progress normally for a while and then plateau and then progress normally again. They may miss motor development milestones. They might be slow to crawl and walk and roll over. And in childhood, they sometimes engage in odd or unusual movements that are not the same, but that might be a very mild manifestation of disorganized behavior later in life. One particular aspect of the schizophrenia endophenotype that people with a lot of risk genes for psychosis, but without psychosis themselves, still show impairment in, is what's known as smooth eye tracking pursuit, where the muscles in the eyes should be able to move the eyeballs to follow an object across the midline of the body, across the visual spectrum. That is a fine motor control process, and it's automatic for most people, but people with a lot of risk genes for schizophrenia have difficulties with that fine motor control. And so when they're doing that task, their eye movements are sort of jerky and irregular. People with a lot of risk for schizophrenia show attentional deficits, so they have trouble focusing and concentrating in early childhood. They have relatively poor social functioning. They may be less emotionally reactive, less emotionally expressive. They may have some communication deficits. They're often described as shy and withdrawn children who might not be as motivated for friendships and pure relationships as other kids. And they show some subtle deficits in recognizing other people's emotions. This one is a little bit more controversial, and it's not replicated in every study, but in some studies of high-risk children with schizophrenia genes, they have been shown to have relatively lower IQs. Not that they have cognitive impairment, but just on average, the IQ of children with a lot of risk for schizophrenia tends to be lower than the IQ of children without that risk. What seems to be actually more specific to the high-risk spectrum for schizophrenia is having a downward trajectory in IQ. So IQ should be relatively stable across the lifetime, and showing a downward trajectory is a sign that there's a neurodegenerative process happening even before the onset of full-blown psychotic symptoms. And that downward IQ trajectory is actually really specific to predicting which high-risk children will go on to develop full-blown psychotic symptoms. It's not something that necessarily distinguishes all high-risk children from control children. So all of these early endophenotypic deficits are sort of like mild versions of the deficits that we see in schizophrenia. So mild versions of disorganized behavior, mild versions of disorganized thought, and mild versions of negative symptoms. So some protective factors that have consistently come up in high-risk studies, one of them is social class, so socioeconomic status. And social class is probably a protective factor because it means better nutrition and better medical care. It means better educational opportunities and a greater chance of early intervention if a child is demonstrating some of these small motor abnormalities. And it means less stress in childhood. And stress is really important for the onset of all the disorders that we're going to be talking about, and schizophrenia and psychosis is no exception. Stress early in childhood causes subtle deficits in motor development and all cognitive development. And people who are at risk because of their high-risk genotype are even more sensitive to things like stress, impairing their motor development. One environmental protective factor that's not related to social class is positive parenting. So high-risk children who have parents who are warm and responsive, as opposed to harsh and punitive, tend to have better outcomes. Okay, so that was the pre-morbid stage of the schizophrenia endophenotype. Now I'm going to talk a little bit about the prodromal phase, which is the phase right before the onset of acute psychotic symptoms. So the phase before someone would cross the threshold into meeting criteria for brief psychotic disorder, wow, my mind just went blank. Brief psychotic disorder, schizophreniform disorder, or schizophrenia. Before they meet criteria for any of those, they're in the prodromal phase. And during the prodromal phase, there is evidence for what's known as attenuated psychotic symptoms, attenuated psychosis. And attenuated basically just means not quite as intense, not quite as severe. So kids in the prodromal phase will show attenuated asocial behavior, attenuated apathy, attenuated anhedonia. It's not as pronounced as it is when it's a clear-cut negative symptom of schizophrenia, but it's evident in their behavior. There might be also attenuated positive symptoms, so mild delusions like paranoia or having some weird beliefs, or mild perceptual alterations, so very mild hallucinations. There are also non-specific signs that a child is in the schizophrenia prodrome, like worsening academic performance, withdrawing socially, and having mood symptoms. So I'm going to show two brief demonstrations of people talking about what their early life and what the schizophrenia prodrome felt like for them.
Hi, my name is Lauren, and I'm going to be making a series of videos talking a little bit more about my experience with mental illness as well as schizophrenia and schizoaffective disorder, and to just kind of give a little bit more information for people who are newly diagnosed and looking for more resources, or for their loved ones who are looking for better ways to support them, or for people who just want to know more. So in this first video, I'm going to be sharing a little bit more about my own personal story with schizoaffective disorder. Jumping right into it. Again, my name is Lauren, and I was diagnosed with schizoaffective disorder in 2015 at the age of 25. It took several years of struggling as well as misdiagnoses to arrive to this point, though, and so I'm just going to share a little bit more about what that entailed, as well as what living with this illness looks like for me. So starting with my childhood, it was fairly normal, though I was definitely a little bit more of a quieter kid and at times kind of struggled with socialization with some of my peers, which may have been an early warning sign or indication or symptom of something to come, but I didn't really start struggling until my teenage years. I always did quite well academically, and I really loved to read and learn, but something kind of shifted though in high school, and I began to struggle with my mood and what I can now identify as what were some negative symptoms of schizophrenia, which led to an increased apathy in participating in school, as well as just kind of generally withdrawing from people and just from life. So this is when I also started to experience thought broadcasting, so where I thought that people could hear my thoughts. Which again was an early indication or warning sign of something to come that I can now identify in hindsight. I skipped a lot of classes, which led to lower grades, but I was still able to scrounge together decent enough grades to not raise too many red flags, but it was still a problem. The sense of apathy resulted in me not really being sure of what I wanted to do after high school, but I decided to enroll part-time at the University of Alberta, taking political science and psychology. I was still struggling quite a bit though, and so with a little encouragement from my boyfriend at the time, decided to visit a family doctor to just kind of see what was going on with me.
Okay, so there she talked a little bit about some of the early pre-morbid clinical signs, so mild social communication deficits, mild difficulties socializing with their peers, and then some of the attenuated negative symptoms during the schizophrenia prodrome, like anhedonia, apathy, asociality, and also some of the more non-specific signs like worsening school performance, increasing mood disorder symptoms, and becoming socially withdrawn.
So in high school, I was, kind of popular. I played football. I had a lot of friends, I was gregarious and outgoing. I was just a likable guy. Everybody seemed to like me. The first inklings I had probably were when I would have some kind of thought and I would say it out loud to my friends and they'd be like, what are you talking about? Or something that sort of half connected to the thing that was going on. And I would express this thought and people were like, that's crazy, Mike. So I think
Okay, so that's an example of possibly an attenuated delusion, so having odd or unusual beliefs. Could also be a sign of attenuated disorganized thinking. So he mentioned tangentiality or loose associations, bringing things up that seemed connected to the topic at hand to him, but that other people couldn't see the connection.
And two.
Okay. So some people, because there's so much evidence that there is a specific time period before the onset of psychotic symptoms where people have prodromal or attenuated symptoms, there's been an argument to add a fourth schizophrenia spectrum diagnosis, attenuated psychosis, to capture people who are in the prodromal phase of schizophrenia. So there's two arguments for this. One is that early intervention, intervening as soon as the first psychotic symptoms emerge, improves someone's chance for having a full recovery. So intervening during the prodromal stage actually even further improves their chances of never progressing to full-blown psychotic symptoms and having better functioning. It's also true that a given person who has these attenuated psychotic symptoms doesn't necessarily have to progress to full-blown psychosis and schizophrenia. There are some people who kind of stay in this prodromal attenuated phase for a really long time or even for their whole lifetime. So this diagnosis could capture not just people who are in the early stages of schizophrenia, but it could capture people who have a distinct clear-cut diagnosis who are never going to progress to schizophrenia, but still have mild psychotic symptoms and mild impairment. Oops, sorry, this bit is repeated. All right, well, the video worked that time. Okay, so now I'm going to talk a little bit about what is happening in the brain during the acute phase of schizophrenia. So the progressive phase, when someone has all of the psychotic symptoms and is having that kind of waxing and waning course, and then the residual phase, which is what is believed to happen after the clinical disease process of schizophrenia has reached its conclusion and caused lasting, permanent structural changes and damage to the brain. So schizophrenia is a neurodevelopmental disease, as we talked about in previous slides. There are early signs of subtle cognitive deficits that appear early in development before any psychotic symptoms arise and that result in subtle developmental impairments, especially related to social communication and motor skills. Schizophrenia is also a degenerative disease. So what these images are showing is changes in gray matter, which is the neuronal cell bodies in the brain, over a 5-year period in adolescents who had their first psychotic episode. So this is at baseline. Areas that are warmer colors, so areas that are more pink, are areas where there are already gray matter deficits compared to their peers. They already have fewer cell bodies than they should. And this part of the brain is really involved in motor control and sensory processing. 5 years later, the deficits have spread and gotten more pronounced. So now kids with schizophrenia have even more widespread deficits in gray matter as a result of the degenerative process of psychosis. Later in life, in adulthood, after more years of psychosis, this brain shrinkage is even more evident. So you can see progressive brain shrinkage as enlargement of ventricles. Ventricles are the fluid-filled spaces in the middle of the brain. And as gray matter shrinks, the ventricles get bigger. There's just more sort of empty space in the brain and it gets filled up with fluid. So these MRIs are identical twins, where one twin has schizophrenia and the other one does not. The ventricles in the twin unaffected by schizophrenia are much, much smaller than the ventricles in the twin affected by schizophrenia. So this is showing that theoretically, these two started out with mostly identical brains, but over the course of their development, schizophrenia affected the brain of the affected twin in a way that caused brain shrinkage. Ventricle size, it's a little bit more complicated than this because ventricle size can also be an endophenotype. People with schizophrenia risk genes, but without schizophrenia itself, may show slightly larger ventricles compared to the general population. But the clearest illustration is what is between twins, where one is affected and one is not. This shows the progressive nature of schizophrenia. So let's talk a little bit about the genetics of schizophrenia, because schizophrenia is clearly caused by biological abnormalities, and those abnormalities are mostly attributable to genetic variation. So 80% of the variance in the biological abnormalities that cause schizophrenia is genetic. It's explained by genes. And we know this because the risk of having schizophrenia goes up exponentially the closer you are related to someone who has it. So someone with no family history of schizophrenia has about a 1% chance of developing the disorder. That's the population base rate of schizophrenia. So knowing nothing else about a person except how common schizophrenia is, that's how we come up with this 1% estimate. Someone who has a sibling with schizophrenia, so a sibling shares on average about 50% of your genes with you, has a 7 to 10% chance of developing schizophrenia. That goes all the way up to someone who has an identical twin with schizophrenia, or a parent with schizophrenia, or sorry, 2 parents with schizophrenia. These estimates are ranges, but the estimate that your textbook gives for both of these conditions is 50%. So if your identical twin has schizophrenia, you have a 50% chance of developing the disease yourself. For someone who has only one affected parent, the chances are much lower, but still way higher than the population. The estimate the textbook gives is 17%. However, not every case of schizophrenia is explainable by family history. So there are people with schizophrenia who don't have a family history of the disease and whose parents are not affected. So the people who gave them their genes that we do know caused schizophrenia, the genes caused schizophrenia, but the parents didn't have schizophrenia themselves. There's also cases, again, of identical twins who share 100% of their genes, where one twin is affected by schizophrenia and the other is not. Interestingly, though, the children of the unaffected twin have the same probability of developing schizophrenia as the child of a parent with schizophrenia. So even though that twin doesn't have schizophrenia themselves, their genes have convey the same level of risk for their children as if they did have schizophrenia. So that shows that someone can have high-risk genes and not be affected themselves. Another example is when twins are concordant for schizophrenia, when they both have the disease, they don't necessarily have to be concordant for severity. So one twin can have a much more severe disease process than the other. And while polygenetic risk can explain how a child with no family history can show signs of schizophrenia, both parents coming in with some level of genetic risk that isn't enough to cause the disease or the endophenotype in them, but when combined causes the disease in their child. These other cases of unaffected identical twins or concordant twins with different disease processes, that can't be fully explained by genes because twins share 100% of their genes, identical twins. So we have to think about the role of the environment in schizophrenia too. What this figure is showing is basically maternal stress and illness during pregnancy or problems and complications during birth are the biggest causes, environmental causes of schizophrenia. What all of these things have in common, so maternal infection, maternal stress and deprivation during pregnancy or obstetric complications, what they all have in common is stress and an impact on fetal development or an impact on brain development right at birth. So to make sense of this figure, I'm just going to quickly explain that basically all an odds ratio is a risk multiplier. So if you think of having a 1% baseline risk, these risk factors multiply that by a factor of, in the case of famine during pregnancy, multiply it by a factor of 2. So a child whose genes convey a 1% risk of schizophrenia now has a 2% chance of developing schizophrenia if his mom went through a period of starvation during her pregnancy. And we know this because historical cases of famines have been studied and the population prevalence in the next generation has been found to be higher for schizophrenia. So all of these environmental insults can negatively influence brain development in utero or brain development shortly after birth. And that's what they all have in common. The environment interacts with genetic risk for schizophrenia by causing further stress on an already vulnerable neurodevelopmental system. So it's important to remember that environmental risk factors don't cause schizophrenia in the absence of genetic risk. What they are more likely to do is to multiply genetic risk or to activate genetic risk. So one example of the prenatal environment in schizophrenia is an example of twins who were concordant for schizophrenia, but discordant for how severe their illness was. And actually they're not twins, they're identical quadruplets. So 4 girls who all shared identical genes, even though their genes were identical, their IQs were really discrepant. One girl had a totally average IQ, and one of the quadruplets had an IQ that was on the borderline of intellectual disability. So these quadruplets, shared a prenatal environment, but even though they all were in the same womb, that doesn't mean that they all had the same conditions. Twins compete for resources in utero. So some twins get better blood supply and better oxygen supply, and their development might be benefited relative to the other twin. And these obvious differences in prenatal environment that cause differences in IQ, also differences in height, Hester was the shortest and Nora was the tallest, suggest that Hester had more prenatal risk factors than Nora did. And that corresponded to Hester having a more severe illness course than her sister. So this illustrates how the environment can influence the severity of psychotic symptoms in someone who has super high genetic risk. Okay, so I said we were going to talk a little bit about the relationship between dopamine and psychotic symptoms. Okay, so the oldest hypothesis for what brain abnormalities could cause schizophrenia is the hypothesis that schizophrenia is caused by overactive dopamine production in some areas of the brain and underactive dopamine signaling in other areas of the brain. Specifically, underactive dopamine signaling in the prefrontal cortex, which is the part of the brain involved in organizing our thoughts, in sort of organizing our sensory experiences and behavior into our conscious and intentional behaviors. So basically, the prefrontal cortex is the interpreter for activity in the rest of our brain. And the theory is that people with schizophrenia have underactive dopamine signaling in the prefrontal cortex, which translates to sort of reduced and impaired regulatory activity in their brain. The hypothesis is that overactive dopamine signaling in the limbic system, so in the amygdala, is responsible for positive symptoms, so for having a lot of emotional or experiential symptoms that aren't real. And underactive signaling in the prefrontal cortex is responsible for negative, cognitive, and disorganized symptoms. And dopamine signaling and all neurotransmitter signaling can be influenced by density of receptors. So people with hypofrontality might just not have enough dopamine receptors. It can be caused by problems with dopamine breakdown. So breakdown is happening too fast for dopamine to signal in the way that it should. Or it can be caused by problems with dopamine production. So not enough dopamine is being produced. Most antipsychotic medications are dopamine antagonists, which means that they work to reduce dopamine signaling throughout the brain. And we do know that these drugs can be really effective in treating positive symptoms. So there is a clear role for the dopamine system in positive symptoms. We also know that dopamine agonists, so drugs that mimic the activity of dopamine, like amphetamines and cocaine, can cause psychosis. So there is a role for dopamine in psychotic symptoms. However, it is a little bit more complicated than that. So the other neurotransmitter that's implicated in psychosis and schizophrenia is glutamate, which is an excitatory neurotransmitter. So typically when it binds to a receptor on a cell, the effect of glutamate is that that cell will fire more of its neurotransmitters. And glutamate receptor antagonists like ketamine and PCP can also cause psychosis. So these drugs don't have a direct effect on the dopamine system like cocaine and amphetamines do, but just like cocaine and amphetamines, they can cause psychotic symptoms. So glutamate signaling in the prefrontal cortex actually helps to regulate dopamine production and dopamine signaling to the amygdala. So malfunctioning glutamate in the prefrontal cortex could be a very early stage in the pathology of schizophrenia where glutamate becomes dysregulated first, and downstream that causes dysregulation of dopamine production. It's also notable that glutamate is an excitatory neurotransmitter. So like I said, when it binds to a receptor, it makes that cell fire. There's a phenomenon known as excitotoxicity, where if a cell is overstimulated, it eventually fires too much and dies. So it's possible that some of the neurodegeneration that happens in schizophrenia is a product of excitotoxicity caused by dysregulated glutamate signaling. Okay, so that's just a really brief overview of some of the neurotransmitters that might be involved. The important takeaway is that probably both dopamine and glutamate are dysregulated, and one reason why the drugs that we have available now don't work equally well for all symptom domains is that they're not all caused by dopamine, and also that it's not just too much dopamine throughout the brain that causes problems. It could be too much dopamine in some areas and not enough in other areas. So a drug that only works by blocking dopamine would only work on those symptoms that are caused by overactive dopamine, and it wouldn't work on any symptoms that might be caused by underactive dopamine. Okay, so this is just another demonstration that problems with glutamate specifically can cause psychosis in someone who does not have schizophrenia. This is a famous case of a disease called anti-NMDA receptor encephalitis, which is an autoimmune disorder where the body attacks NMDA receptors, so the receptor for glutamate, causing insufficient glutamate signaling in the prefrontal cortex. So it's an example of psychosis caused by an organic disease process.
It all started with when I thought I had a case of bed bugs. And when I had an exterminator, he came in and said, "You don't have bed bugs." Then after that, I was feeling very tired and lethargic, and really, I just didn't want to go to work. I felt not like myself. And then I started having numbness in my hands and my feet. And at that point, I went to a neurologist who first diagnosed me with mono. After that, I started acting paranoid. I had hallucinations, and then I had a seizure. Because I literally don't remember the good part of the month that I was in the hospital, I had to rely on medical records, interviews with doctors, interviews with my family, interviews with my boyfriend. You know, pretty much I had to just recreate that time using the skills of a journalist. There's video that exists of me in the hospital, and when I watch it, it's very much, I'm watching this other Susanna, this other person that is so far divorced from who I am now. I mean, she's frightened, she's angry, she's just terrifying. And in a lot of ways, I've been trying to reconcile who that person was with who I am now, and what part of me is this kind of monstrous person. And through the course of researching this, I've come a little bit closer to understanding that other Susanna, but she's always a stranger. She's someone who I have to dig really deep outside of myself to really understand. I have to ask other people. I have to read pages of medical records to get anywhere close to understanding who that person was. Towards the end, I stopped being paranoid, and I stopped having these unbelievable hallucinations, and I started becoming catatonic. I hardly moved. I had no emotional register. I just kind of stared off into space. I had very rigid movement. And basically,
so that's catatonic.
Now I know, looking back then after my research, that I was heading towards what would most likely have been a coma, and for some people, death. I was ultimately diagnosed by Dr. Suel Nujar at NYU. He was the first doctor to really sit down and see the whole picture, the bed bugs, the paranoia, the hallucination, the catatonic state. He also noticed I had high blood pressure. At one point when he visited me for the first time, he did something that no other doctor asked me to do. He asked me to draw a clock. And it's a very simple procedure. I had gone through $1 million worth of blood tests, MRIs. This is one clear step that he asked me that cost nothing. Basically, he gave me a piece of paper and asked me to draw in 1 through 12. And I drew every single one of those numbers on the right-hand side, which showed that I had inflammation in the right side of my brain. After a brain biopsy and a spinal tap, they ultimately diagnosed me with what is called anti-NMDA receptor autoimmune encephalitis, which is, in short, when your body's immune system attacks the brain. The hardest part for me was the recovery, and it was the hardest part to write as well. At that point, I had lost my identity, who I was. Everything about my personality was just gone, and I had to rebuild that from scratch. I'm reminded of the scar I have from my brain biopsy on my head, and I know I'll never be the same person that I was before. And I think it's given me such purpose in my life, because I feel like this story and living through this horrible time has given me, the strength to help other people and the ability to help other people, which I think is the most wonderful gift of the whole thing.
Okay. So that's just an example of how psychosis is caused by an organic process. In this case, it's really clear that her body's immune system was attacking her NMDA receptors. The disease process that causes schizophrenia is less clear, but it very likely involves malfunctioning in the glutamate system. Okay, so some takeaways from the schizophrenia spectrum, and we are very close to being done. So the prevalence of schizophrenia is a little difficult to estimate because many people who have schizophrenia are marginalized and unable to seek the level of intense treatment that this disease requires. So many never even get diagnosed. The lifetime prevalence is probably on the 1% side for schizophrenia itself, and higher, so 1.5% for the full schizophrenia spectrum. Although again, people with less severe psychotic symptoms similar to delusional disorder may never get diagnosed. Schizophrenia, as we know it, is a severe and debilitating disorder. It's among the most serious mental illnesses in that it has a really poor prognosis. 80% have a chronic progressive course that involves neurodegeneration and worsening functioning over the course of their life. And as many as 5% of patients with schizophrenia complete suicide. Many people with schizophrenia are so severely impaired that they're unable to live or work independently. And as a result, there's a really high rate of homelessness in this population. Schizophrenia is highly heritable. The endophenotype of schizophrenia is evident really early in life with slightly impaired motor and social development. The risk of developing full-blown psychosis is enhanced by insults during fetal development and really early in life that can contribute to problematic neural development. Over time, schizophrenia is neurodevelopmental in that there are early emerging problems in development that are related to impaired circuitry development in the brain. It's also neurodegenerative. So once psychosis begins, there is cell death throughout the brain that's evidenced by larger ventricles later in life. And the disease process of schizophrenia is characterized by disruptions in dopamine and glutamate pathways in the brain. And these are linked to both positive and negative symptoms as well as cognitive symptoms. It's possible that some of the cell death in schizophrenia may be caused by excitotoxicity. So cells are too active, the brain is too overexcited. And there are some specific deficits in brain processes that we have begun to identify, like deficits in communication between the perceptual system and the emotional system, like we talked about with Capgras delusion, which was a specific deficit in communication between visual processing and emotional processing. And problems with sensory gating and sensory habituation, causing people with psychosis to be inundated with meaningless sensory information that their brain then tries to make sense of. The best prognosis for schizophrenia involves better premorbid functioning, so having fewer prodromal symptoms, less attenuated psychosis, having a high IQ, having good premorbid social functioning, good relationships, basically a safety net and social support. The best prognosis is for people who have no negative symptoms. And also the best prognosis is for people who have the shortest possible duration of untreated psychosis, because psychosis is a degenerative disease process. Okay, so moving really quickly on to cluster A personality disorders. I may have accidentally not included schizoaffective disorder in this, and that is okay. So the cluster A personality disorders, and we will get more into detail on what personality disorders really are in a subsequent lecture. Cluster A personality disorders can best be understood as subclinical, chronic, and persistent attenuated psychosis. So schizotypal personality involves chronic mild positive symptoms like delusions and hallucinations, and mild disorganized symptoms. So odd, unusual behavior, some difficulty discerning between internal and external experiences, but no full-blown acute psychosis. Schizoid personality disorder involves chronic mild negative symptoms, so lack of motivation, especially in regards to social motivation, mild anhedonia, mild avolition, just kind of a withdrawn, uninterested personality. And then paranoid personality involves chronic mild symptoms of delusional disorder. So having odd or unusual beliefs with a theme of persecution and paranoia. And we can kind of think of the cluster A personality disorders as being adjacent to the schizophrenia prodrome. So symptomatically, they look really similar, but by definition, a personality disorder never progresses into full-blown schizophrenia. This is what happens when someone stays in the schizophrenia prodrome or consistently has attenuated psychosis and never progresses. It often happens that someone will get a diagnosis of a cluster A personality disorder symptom while they're in the prodrome and then progress to acute psychosis. That's a misdiagnosis. Cluster A personality disorder, by definition, should never progress to schizophrenia, but it can be very difficult to distinguish personality disorders from the schizophrenia prodrome. Okay, so last thing. Schizoaffective disorder is basically a diagnosis for people who have really severe and impairing features of both mood disorders and psychotic disorders. It has all the same symptoms of schizophrenia, so 2 or more psychotic symptoms, impaired functioning in every domain, a lack of achievement if it starts in childhood, plus co-occurring and independent mood symptoms. So when psychosis only ever co-occurs with mood symptoms, that is a mood disorder with psychotic features. For schizoaffective disorder, mood symptoms have to occur both independently of and concurrently with psychosis. And psychosis also has to occur independently of mood disorder symptoms. So schizoaffective disorder has a really similar prognosis to schizophrenia. It is also a neurodegenerative disease, also with a worsening course over time, and a similarly high relapse rate. There is some indication that the outlook is a little bit better because so many of the mood disorder symptoms can be effectively treated, even when some of the psychotic symptoms can't be. So the dominant treatment for psychotic spectrum disorders is medication. And the medications that we have, antipsychotics, are most effective for positive symptoms. They decrease the frequency and intensity of hallucinations and delusions. They help people distinguish between what's real and what isn't. And almost all antipsychotics that we have are dopamine antagonists. So they work to calm down the dopamine system. But as I said, that effect is not very specific. And probably what's happening in the brains of people with schizophrenia is that dopamine is too active in some areas and not sufficiently active in other areas, like the prefrontal cortex. So sometimes a drug called Provigil, which is a drug for narcolepsy, it helps people be more awake and alert, is given for disorganized and negative symptoms, but really there is no recognized drug treatment that really helps negative symptoms. Medication noncompliance is a serious problem for schizophrenia, even more so than for bipolar disorder, because the side effects of medications like antipsychotics are so unpleasant and so hard to live with. So first generation antipsychotics had a lot of extrapyramidal side effects. Like I talked about in the video of the woman with really slurred speech, these drugs caused problems with motor coordination. They also caused random meaningless movements and twitchiness. And those side effects persist even after the person is off the drug. So those drugs are really difficult to take and live with. Atypical antipsychotics, so second generation antipsychotics, have fewer extrapyramidal side effects, but they cause huge metabolic problems. So taking atypical antipsychotic drugs over time can cause metabolic disease and cause diabetes. These drugs also are associated with a lot of weight gain, even in the absence of appetite changes. So they just change your metabolism and make it really difficult to maintain a healthy weight. Antipsychotic drugs also have some cognitive side effects where people might feel sedated or groggy or have difficulty with word finding. So they're hard drugs to take. It's very difficult to live with these medications, and treatment for schizophrenia often involves a lot of medication changes to manage side effects while managing symptoms. The psychosocial treatment of schizophrenia is based on observations that there are actually better outcomes for schizophrenia in developing countries than there are in the United States. Part of that results seemingly from cultural understandings of schizophrenia. In most Western countries, we think of it as an incurable brain disease with a terrible prognosis, which is true, but that definitely affects the way that family members and society treat people with this disease. It's highly stigmatized. It's seen as this devastating, life-altering, life-ending diagnosis, whereas in other countries, other cultures, it is more likely to be perceived in a more similar way to a mood or anxiety disorder. It's a personality trait, it's an individual difference, it's a response to stress, it's a nervous disease. It's something that can be managed more easily, and it's not seen as such a devastating diagnosis. And that really seems to help with social integration and family support. Families are more able to integrate the person with schizophrenia and have them live a productive, meaningful life within the family. The textbook talks a little bit about expressed emotion, and this just has to do with how families communicate with each other around the disease and around the patient's behavior. In families with really high expressed emotion, there's sometimes an unconscious, subtle blaming of the patient for their disease. Whereas in families with low expressed emotion, the problems of the patient's behavior are seen as more outside of their control and less characterological. And low expressed emotion seems to be better for recovery, not just from psychosis, but from all forms of psychopathology. Over time in the United States, treatment of schizophrenia has moved to focus on better integration into society. So deinstitutionalization, helping people live independent lives, focusing on teaching life skills and social skills, and integrating people into the community by helping them find employment, and into their families by helping families learn to communicate better. There's also cognitive remediation treatments, so trying to help improve the cognitive deficits that can be caused over time by psychosis. And treatments focused, psychosocial treatments and CBT treatments focused on managing and reducing stress, because stress can be a trigger for worsening psychotic symptoms. Okay, I'm gonna skip over this video, but this is just someone talking a little bit about his experience with being treated for psychosis and how these three threads, so medication adherence, social and family support, and vocational functioning, all come together to help improve the prognosis and outcome of schizophrenia. Okay, so there are your extra credit and further readings. Oops, this link is broken, so I'll fix that. So just as a reminder, if you want to change your grade before the midterm, You can read any of the extra credit readings in any of the lectures and write a 500-word response paper about it for 1 additional point on your overall grade point average. So taking you from like a grade of 92% to a grade of 93%. Okay, thanks for watching this kind of long lecture.